So basically, what is pelvimetry? What do you mean by metry? Metry means measurements. Pelvi means it has been taken from pelvis. So various measurements of pelvis, that is what we are going to study today. So basically this is a core obs and gynae topic. So this is a topic from your obstetrics and gynecology, but it has been given in your competency, so it has to be covered. Usually, like during our times, we were given only the bony pelvis, like identify the bones and how they are joined with each other. But in the upcoming curriculum, you have been given with certain clinical topics. So pelvimetry has been introduced in your new CBME guidelines, so it has to be covered. But what to say? Give importance to the topic. But since this is a small portion of your osteology, pelvimetry has been taken from two words. One is pelvis, another one is metry. Metry means your measurements. So today we are going to study about the various measurements of pelvis. But before that, let us have certain understanding of what is pelvimetry. So pelvimetry is the measurement of the dimensions of pelvis. Now it is of two types, basically two types. One is your clinical type. So as the name suggests, it is clinical. So you are doing the clinical examination of the patient and determining the various dimension of the pelvis. So this is carried out manually. So next type is radiological. So the clinical pelvimetry is carried out manually by a doctor. Okay, so your radiological pelvimetry is carried out using various radiological modalities. So what are radiological modalities? Your X-ray, CT pelvimetry and MRI. Now this is an X-ray machine. You will see this in your various hospitals. So this is any hospital setup, you will see this machine, which is your X-ray machine. Then comes your CT machine. On the lower left side is your CT machine, which is almost similar to your MRI machine, which is on the lower right side. Now why I have written MRI as the safest? So during pregnancy, it is advised to give as low as radiation to be given to the patient, because the mother is carrying the fetus. So the amount of radiation that you will be giving, if it is more than the recommended dose, then there can be certain anomalies in the fetus. What I am trying to say, that the mother is carrying the baby. So if I give multiple radiations to the mother, the baby will be affected. The general growth of the baby will be affected, and the baby will be born with certain congenital anomalies. So X-ray is usually avoided. That doesn't mean that we are not going to do any X-ray whenever there is necessary. We will do X-ray. Usually you don't need to remember these terms, but there is certain units which through which we determine the safety level. One is your 0.5. So usually while giving radiation, we usually give within this much radiation, it is allowable to be given to a mother. Okay, don't write this. Okay, so in X-ray, you are giving one ray. Similarly, what is CT pelvimetry? CT means your computed tomography. You have heard this term, CT scan. So this is on CT scan machine, where we do CT scan of the pelvis. So it is computed tomography. So the basic difference between an X-ray and a CT scan is that in CT scan, you are going to study the whole structure slices by slices. So if you observe anytime if you observe the CT scan machine, you will see that all the structures are present in various slices. We call them CT slices. So it depends upon whether you want to give any contrast or not. Depending on that, it is known as contrast CT scan or non-contrast CT scan. If it is non-contrast, then we call it NCCT or non-contrast CT scan. And if it is contrast, then we call it CECT, that is contrast enhanced CT scan. Okay, so in contrast enhanced CT scan, we usually inject one chemical inside the through the veins, and after that we take the CT scan. Okay, here it is only written CT pelvimetry. So here also involvement of rays are there. So we usually avoid these two modalities. But MRI is safe, because in MRI there is no ray, there is magnetic resonance imaging. So various magnets. This whole structure is a magnet. So various magnetic coil is present here. So this does not involve any any radiation. Okay, so it is magnetic resonance imaging, that is your MRI. So basically what happens in MRI, it is always advised that you don't carry any metallic particles with you. So you will see that whenever the patient is taken to a MRI machine, MRI table, you will see that any metallic substances will not be taken with the patient. So if you are having any RCT in your tooth or any nails in your body, nails means what? In any orthopedic surgery, sometimes nails are kept. So if nails are present, then you cannot allow MRI to be done. Okay, so always proper history is taken from the patient, whether the patient is having RCT. Do you know what is RCT? Root canal treatment. So in root canal treatment, there are certain metallic substances are put inside the root, so and it is covered. So that is known as root canal treatment. So in that, the substances are used, those are your metallic substances. So these metallic substances can easily be taken out in this magnetic field. Okay. Now coming to what is the various bony structure in a pelvis. So here, what is these two bones? Hip bones. This is your hip bone. Then what is this bone? Sacrum. And this one? Coccyx. So these are yours. This is your sacrum, this is your coccyx, and these are your two hip bones. Now coming to this structure. So this is the view whenever you view the pelvis from your anterior way. That is your anterior view of the pelvis. So here you can see various ligaments of the pelvis. Here you will see this is your anterior longitudinal ligament. If you remember the vertebral column class, I have told that the anterior longitudinal ligament will be passing anterior to the vertebra throughout the vertebral column. That is your anterior longitudinal ligament. Similarly, on either side will be your iliolumbar ligament. Why iliolumbar ligament? Because this is your ilium. From this, the ligament is joining the lumbar vertebra. So this is your iliolumbar ligament. Similarly, ilium to femur is your iliofemoral ligament. Then pubofemoral ligament from your pubis to your femur. Then there is your sacrotuberous ligament and sacrococcygeal ligament. Then this is your obturator foramen. This is your obturator foramen. This is your acetabulum, where the head of the femur is attached. And this big structure is your ilium, then pubis. This one is your pubis, then your ischium. Here you will see, and this is your subpubic angle. We will study this later on. Now, what is this structure? So the whole pelvis is dividing the pelvic cavity. I mean, the whole structure of the pelvis is divided into greater pelvis and lesser pelvis. Greater pelvis is your false pelvis, lesser pelvis is your true pelvis. How we determine these two pelvis? So this is your pelvic brim. Okay, this is your pelvic brim. We will study the boundary, then it will be clear. Above the pelvic brim is your false pelvis. Below the pelvic brim is your true pelvis, and this true pelvis is important for us. Okay, one thing. So why we are studying this pelvis so much in details? Why is this opening is that much important that we are taking multiple classes, like in obs and gynae it is studied, in anatomy it is studied. Why this is so much important? So this is basically your birth canal. Okay, so depending on this, it can be determined whether the baby will be having normal vaginal delivery, whether the baby needs your cesarean section. Okay, depending on this pelvic inlet, it can be determined. So in the first slide, I have shown you that clinical pelvimetry is carried out by a doctor. So during that time, what the doctor does, you will see that whenever the mother is brought to the any gynae OPD, you will see the doctor inserts one or two fingers depending on the opening of the vaginal canal. They insert it and check the position of the pelvis or the vaginal canal. So it has two functions. So basically, in unmarried patients, we usually don't do vaginal examination, but in case of any expected mother or pregnant woman, we usually do vaginal examination. In that vaginal examination, 2-3 things we determine. One is your Bishop score. So Bishop score is not important. In Bishop score, what we do, we determine the various position of the fetus. So suppose the mother is going to deliver the baby. Now we need to determine whether the mother needs normal vaginal delivery or cesarean section. How to determine this? So the gynecologist, what he or she does, inserts 2 fingers and checks the cephalopelvic disproportion. What is cephalopelvic disproportion? Cephalo is head, pelvis is pelvis. So cephalopelvic disproportion is the disproportion or the difference between the pelvis of the mother and the head of the fetus. So suppose there is cephalopelvic disproportion, that is the head is bigger than the cavity of the mother. So in that case, it is ideally prescribed to do your LSCS or lower segment cesarean section or simply cesarean section. Now, and then if normal vaginal delivery is expected, so in that situation, through this again by vaginal examination with digital, this is called digital examination. You will hear one thing in medical terminology, digital examination. Digital doesn't belong to your technologies. Digital examination means using your fingers. So in surgery also you will see rectal examination, those are also done with digits. So with digital examination, it is determined whether the head of the baby has already come down or not, whether the membrane is ruptured or not. With this we do one scoring that is known as Bishop scoring. That is why this pelvis we need to study in great detail. So determine the various diameters of the pelvis. Now coming to pelvic brim. So the pelvic brim divides the whole pelvis into your true pelvis and your false pelvis. So if you see this picture, here you will see this red line determines your pelvic brim. Okay, where you will see that on the posterior side will be your promontory, sacral promontory, and on either side will be your arcuate line of the ilium. So this is the ilium and this is your arcuate line. And on the anterior surface, anteriorly you will see this pecten pubis and your pubic crest as well as your pubic symphysis. This arcuate line and pubic symphysis along with the pecten pubis, this whole thing together is known as your linea terminalis. So here you will see behind you will of the pelvic brim. So this is basically your pelvic brim. This is your pelvic brim. So here you will see on the posterior surface will be your sacral promontory, on either side will be your arcuate line of the ilium. This is your ilium, these are your iliac fossa. So on either side you will see the arcuate line of the ilium, and on the anterior part you will see this pecten pubis, pubic crest, pubic symphysis together. So this is forming your pelvic brim. Above this portion will be comprising your false pelvis. This is your false pelvis, and this lower part will be your true pelvis, starting from the pelvic brim. So similarly here it is written behind sacral promontory, on either side arcuate line of ilium, anteriorly pecten pubis, pubic crest, and linea terminalis is arcuate line, pecten pubis and pubic crest. So together all these things together they are called as linea terminalis. Now sex differences. So the male pelvis is different from the female pelvis because the female pelvis is more wider so that proper delivery can be carried out. Now there is a chart in your Vishamsing also. This is a more simpler chart, this difference. In all the books there are charts, various charts, but I have seen tabular form in your Vishamsing. I haven't seen VDC, and this is one chart which I have taken from another book, which is in a more simpler way. So the female pelvis and the male pelvis, there are various points, but one easy trick to remember is that everything is wider and larger in case of female. Only 3 things will be wider and larger in case of males. One is your obturator foramen, then sacroiliac joint, and your acetabular notch. That will be wider and larger in case of male. Rest all the points will be wider and larger in case of females. Understood? So everything, suppose the shape of the pelvis will be wider in case of female, pelvic inlet will be larger, coccyx will be more curved and movable in case of female, pubic arch will be wider, subpubic angle, I will discuss this topic, pelvic brim will be large and round, sciatic notch will be wider, obturator foramen small and triangular in female but large and oval shaped in case of male, sacroiliac joint surface will be short and wider in case of female, long and narrow in case of male, pelvic acetabulum will be small and facet shaped in case of female and large and facet in case of female. So only OSA, we remember this with a mnemonic OSA. So these three things will be wider and larger in case of male. Your obturator foramen, sacroiliac joint and your acetabular notch. These three things will be wider and larger in case of males. Rest all things will be wider in case of females. Now this angle will be your subpubic angle. This is your subpubic angle, which will be narrower in case of males but wider in case of females. So in case of males, we usually measure the angle by keeping our index and middle finger. In this way we measure it, and usually it is less than 90 degree. But this is the pelvis of a female. This is a fiber pelvis only, but this is the shape of a female. So here we usually measure it by holding like this, which will be more than 90 degree. So see this. So this is your subpubic angle. This angle is your subpubic angle. So this is in male less than 90 degree. In case of female, it is wider and more than 90 degree. Now the pelvic cavity. So the pelvic cavity, in case of males, it will be like a conical shape. In case of female, it is more of a round shape. What has been depicted here? So basically in case of male, it is a long segment of a short cone, but in case of female, it is short segment of a long cone. What it has been meant by this? Suppose this is a short cone and this is a long cone. Now if I take long segment of a short cone, that is that one, I get a conical structure almost. But if I take short segment of a long cone, I get almost parallel side, and the pelvic inlet is more of a parallel. So it has been shown here. This is a female pelvis, this is a male pelvis. So this is male pelvis, that one is female pelvis. So in short, the male pelvis will be more of conical in shape, the female pelvis will be more of cylindrical in shape. Now coming to true pelvis. So the true pelvis comprises of all the structure below your pelvic brim. The true pelvis consists your pelvic inlet, pelvic outlet and pelvic cavity. Now what is pelvic inlet? So the pelvic inlet is just below your pelvic brim. It will be bounded posteriorly by your sacral promontory, on either side by your arcuate and pectineal lines, and on front by your pubic symphysis. So here it has been written sacral promontory and anterior margins of ala of sacrum. So this is your sacral promontory and these are your ala of sacrum. So this is your posterior boundary, on either side arcuate line as well as your pectinate line, and on the anterior part posterior surface of your pubic symphysis. Similarly, pelvic outlet is there. So pelvic outlet is more of a diamond in shape. So this is your pelvic outlet. So here if you can imagine, this is your two segment. The pelvic outlet is formed by your sacrotuberous ligament also. So here is your sacrum. From here one ligament is coming and reaching up to your ischial tuberosity. These are your ischial tuberosity. So in this way these two ligaments are coming on either side. So they are forming one diamond shape. Okay. So we are getting one anterior anterior surface to anterolateral surface to posterior surface and posterolateral surface. So anteriorly will be your lower margin of pubic symphysis. So this is your anterior boundary. On either side, that is anterolaterally, is conjoint ischiopubic ramus on each side. This is your anterolateral boundary of pelvic outlet. Laterally, ischial tuberosity. Posterolaterally will be your sacrotuberous ligament, which is obviously not present here. So sacrotuberous ligament, and posteriorly this tip of coccyx. So this is forming your pelvic outlet. Now the pelvic cavity. So the pelvic cavity is formed anteriorly by your pelvic surfaces of body and pubic bone, pubic rami, pubic symphysis. Posteriorly by your pelvic surfaces of sacrum and coccyx. Laterally by your pelvic surface of ilium, ischium, below the arcuate line. Basically, what is meant by this? So this is your pelvic brim. Below that will be your pelvic inlet. Then this is your pelvic outlet. So in between everything is your pelvic cavity. So this is your pelvic cavity, which is formed by the pelvic surfaces. This is the pelvic surface of your sacrum and coccyx, and pelvic surface of your pubic ramus, as well as your ischium, ilium, everything. Okay. And below the arcuate line, because arcuate line is formed by your pelvic brim, so it is present below. Now various types of female pelvis. So here you will see this pelvis. Here it is almost anthropoid in nature or heart-shaped in nature. But this is, android in nature. This is more like a heart shape or android in nature. This is more like a male pelvis. So by male pelvis, it is mean that the pattern is like that of a male, but it is a type of female. Okay, android pelvis is a type of a male type pelvis, but it is a type of female pelvis. Okay, so this is more of an android type of pelvis. Now the other types are, first of all, see, this is your gynecoid pelvis, which is the normal pelvis. Here you will see that the anteroposterior diameter is smaller than your transverse diameter. And this is almost present in 40 to 50% of your female patients or female. So it is suitable for easy passage of your baby during delivery. So it helps in proper normal vaginal delivery. But in case of android pelvis, which is there in almost 30 to 40% patient, there is some kind of obstruction during delivery. Here you will see that the anteroposterior diameter will be more than the transverse diameter. In platypaloid or flat pelvis, the pelvis is more like flattened. So the anterior posterior diameter is very much narrow compared to your transverse diameter. And in case of anthropoid, the anterior posterior diameter is very much longer and the pelvis is more narrow. So in these three types, it is difficult for natural normal vaginal delivery. But normal vaginal delivery is more prominent in case of your gynecoid pelvis. So the inlet here, pelvic inlet here, is more like a transversely oval, and here it is more like a heart shaped, as we have seen here. It is compressed, I mentioned this, and it is compressed from side to side. Anthropoid. Now, how to hold the pelvis in your anatomical position? So if you take a coronal section, usually the pelvis is held like this. The bony pelvis is held like this. So this is the position you will hold. So see here, this pubic symphysis and this is your sacrum. These will form 60-degree angle with this horizontal plane. If this is your horizontal plane, this sacrum, if you draw a line from your sacrum, then crossing the pubic symphysis, it will form roughly 60 degree with the horizontal. So you hold the pelvis like this. See that this is the plane of greatest pelvic dimension and this is the plane of least pelvic dimension. So greatest pelvic dimension is from your posterior surface of your pubic symphysis and up to your S2, S3 vertebra. So why this greatest pelvic dimension is necessary? Because here the baby can easily pass through. But this is the plane of your least pelvic dimension. So here there can be certain kind of obstruction. This is your ischial spine. So this is forming your transverse plane of least pelvic dimension, and this is your longitudinal or anterior-posterior plane of least pelvic dimension. Just see these pictures one and forget. Now these are your conjugate diameters. Conjugate diameters means your anterior-posterior diameters. So anterior-posterior diameters or your conjugate diameters, these are necessary for proper passing of the fetus. Here you will see there are three conjugates. One is your obstetrical conjugate, another is your true conjugate, and the last one is your diagonal conjugate. So this obstetric conjugate will be starting from the posterior middle portion of your pubic symphysis up to the sacral promontory, and your this true conjugate, which will be starting from your above the pubic symphysis up to the tip of the promontory, and this diagonal conjugate will be starting from the lower part of your pubic symphysis up to your tip of promontory. And your external conjugate will be starting from your anterior surface of pubic symphysis up to the backward of your L4 and L5. I mean S2 and S3. On the back side of your S2 and S3, or almost like in the tip of the spine of S1 vertebra. That is your external conjugate. These are the diameters at the pelvic inlet. So this is the form of a circle. So these are the various diameters. This is your anterior-posterior diameter, which is roughly 11 centimeter. And this anterior-posterior diameter is formed by the posterior surface of your pubic symphysis up to the sacral promontory. And here is your transverse diameter, which is passing from the this pelvic inlet, pelvic brim. Okay, arcuate line of your pelvic brim on either side. And this is your oblique diameter starting from your sacroiliac joint up to the pecten pubis or pubic eminence. That is your oblique diameter. So here you can see the anterior-posterior diameter is the narrowest, having only 11 centimeter. Then comes your oblique diameter, then comes your transverse diameter. Similarly, on the pelvic outlet, there is another anterior-posterior diameter, which is 13 centimeter. Here it is the largest diameter. Then comes your oblique diameter, which is 12 centimeter, and then transverse diameter between the ischial tuberosity, which is of 11 centimeter. Now this is the table which you need to memorize. So at the inlet, at the pelvic inlet, you will see that the anterior-posterior diameter is the narrowest in the inlet. At the mid pelvis, it goes on increasing. Then the oblique diameter is almost similar in all the various layers of the true pelvis. Then the transverse diameter is largest at the inlet and narrowest at the outlet. So this is your transverse diameter basically. This is your transverse diameter. So it is narrowest at the outlet. See, at the outlet it is becoming more and more narrow because your ischial tuberosity is present like this. So it is becoming more and more narrow. But the anterior-posterior diameter, it is initially narrow due to the sacral promontory, but as you go deeper and deeper in the pelvic cavity, it is becoming wider. So this is the wider anterior-posterior diameter at the pelvic outlet. Now what is this X-ray? So here, try to understand this structure. So here will be your sacrum. This is your sacrum. Some structure of sacrum you can see. This is your lumbar vertebra. Then comes your sacrum. On the tip here will be your coccyx, which is barely visible. This is your head of femur. This is your head of femur. Now, this part is your acetabulum. This is your acetabulum. Here also your acetabulum. Now, here you can see the sacroiliac joint. Sacroiliac joint. Here is the pubic symphysis. Can you appreciate that here the pubic symphysis is slightly broken and taken away? So this is pelvic fracture or pelvis fracture. What is this hashtag? Fracture. Fracture is denoted by hashtag. Okay. So this was actually the last slide. So basically that is your pelvis fracture. So pelvic fracture is very rare. It is not that much common because pelvic bone is such a complicated bone that it is very much difficult to have fracture in your pelvis. So that is up to your bony pelvis. So basically, in bony pelvis, this is a very, complicated topic, because to understand this, you need to have certain understanding of your obstetrics and gynecology also, because there are various diameters. The diameters I have been talking till now, depending on those diameters, we can determine the progression of the baby downwards. So basically, if you do any normal vaginal delivery, which is done by interns, so normal vaginal delivery is usually done by interns, okay. In hospitals, if you do internship, you will do normal vaginal delivery, depending on the setup also. So if you do any normal vaginal delivery, you will see that depending on these diameters, you can determine whether the patient will be having any complications during vaginal delivery or not. If the complication can be managed manually by any forceps, or ventus. So forceps are two instruments through which the head of the baby is taken out like this. You will see forceps. It is shaped like this. This is one forceps, and there will be another forceps like this. So in between these two forceps, the head of the baby is pulled out from the pelvis of the mother. Okay, so this is known as forceps delivery. Similarly, there is one vacuum machine which is known as your ventus. So ventus is used to carry out the head of the baby. Similar procedure. But in certain cases, when there is symmetrically contracted pelvis, what is symmetrically contracted pelvis? The whole pelvis is that much contracted that in any way the head of the baby cannot pass out through the mother pelvis. So in those cases, cesarean section is indicated. Now, contracted pelvis, by seeing the stature of any patient, you can know whether the patient is going to have contracted pelvis or not. How? Because if the female is very short statured, like short statured mean very small height or shorter height, then the pelvis will be more or less contracted. So in those patients, without doing any examination, you can carry out elective cesarean section. Now, since pelvis fracture has come into our topic, pelvis fracture is connected with your urethral rupture. That is your topic. So, urethral rupture, in urethra you have seen that. So, urethra is such a thing that it can be ruptured by any way. Okay. So basically, bony pelvis is that much for your discussion. So the topic is up to that much, nothing more than that. Just try to remember the diameters. Okay, that is for your bony pelvis.